Welcome to this Beyond Zero e-learning module on drug-resistant TB. This is one of the Wits RHI catch-up modules. This particular module will focus on the definitions and diagnosis of DRTB. A key part of understanding the management and follow-up of drug-resistant TB is to be very clear about our definitions. At which point do we consider a patient to be MDR, Pre-XDR or XDR? So let's look at some of our definitions. Some of them will be quite familiar. Monoresistance is a TB strain that are resistant to any of the single first-line anti-TB drugs, and that's specifically for ethambutol, pyrazinamide, and INH. Notice that Rifampicin is included there, but we've actually now created a separate category for Rifampicin resistance. So we now have a category called Rifampicin resistance, or RR-TB, and as it's called, it's obviously any TB strain resistant to Rifampicin detected. And that's specifically come about because we do the GeneXpert, which will show us whether a patient is Rifampicin resistant, and we don't yet know whether that patient has MDR, Pre-XDR, or XDR, but they all can be considered RR-TB, and they're all going to be qualifying for second-line drugs. Polyresistance is somebody who's got more than one resistant pattern on our first-line drugs, so either an INH or pyrazinamide or ethambutol, a combination of those, but never are INH and Rifampicin together. That is a new classification. So, for example, if you've got resistance to pyrazinamide and ethambutol, that will be called polyresistance. But of course, when we start getting really concerned is when we move on to MDR, or what we call multi-drug resistant TB. And the definition of MDR is very simple. It's when a patient is resistant to both rifampicin and isoniazid, but still have access to the fluoroquinolones and the injectables. Those are two key drugs in our drug treatment regimens, and we cannot complete a normal treatment regimen without those. We now also have a definition of pre-XDR, and it's to show us when an MDR is progressing, and these patients actually need XDR drugs. We cannot treat them with the normal MDR regimens. And so these are patients who are obviously resistant to both rifampicin and isoniazid, but they're also resistant to either one of the fluoroquinolones or one of the injectables, so either amikacin or kanamycin or capreomycin. So they haven't lost both those classes yet, but they've got one of those drugs. In one of those classes they have lost. Extensive drug-resistant TB, or XDR-TB, obviously now means that all the classes are affected. So you've lost your rifampicin, you've lost your isoniazid, you've lost one of your fluoroquinolones, and you've lost one of your injectables. So how does TB become resistant? And I'm merely going to mention the two possible pathways that we see, which is very similar to other strains of organisms that become resistant. There's your acquired drug resistance. So this is somebody who's been on TB treatment. TB treatment was drug sensitive when they started. Due to whatever factors, they had not been able to adhere properly to their treatment, and that particular organism, that TB organism, mutates and they become drug resistant. The other pathway is primary drug resistance, and that we'll, for example, see in patients who's had no TB before, never been on TB treatment, and they get infected with a drug-resistant strain from somebody else. Very important to remember that the transmission of DRTB occurs exactly in the same way as the transmission of drug-susceptible TB. It is not more pathogenic, it's not easier to get than drug-sensitive TB. It's the same kind of organism. It has the same effects on the body. The only difference comes in our ability to treat it. There's obviously lots of factors contributing to poor TB treatment outcomes. I'm going to very briefly group them together into those that has to do with issues from healthcare providers, giving the inappropriate treatment, and failing the patient in being able to give them what they need to be able to complete their treatment. And so that includes not giving enough support, not giving them enough patient education, missing things when we're monitoring them, and not managing their response to treatment properly. And in MDR-TB, because it's such a long and complicated treatment, it's actually very reliant on healthcare providers providing good service. A major factor with drug resistance is always the constant access to drugs, and here again we have to take responsibility to make sure we are ordering, storing, dosing, dispensing, and making sure that we have formulations that's easy for our patients to take and that they always have a steady supply of medicines that they have access to. And then, of course, there's lots of patient factors. Personal, social, and structural barriers can prevent patients from taking their treatment well. It can include them having other illnesses, mental health issues, the horrible adverse events we can see on some of these drugs, and just challenges. Being able to get to somewhere where they can have an injection on a daily basis can be a real barrier to regular treatment. MDR-TB needs to always be in the back of our minds whenever we see somebody who's presenting with TB symptoms. Some scenarios obviously will make us more suspicious, especially in all retreatment patients or treatment failures. So these are patients who are taking their treatment, but they're getting worse. Patients who their smears do not convert even after 3 months of intensive treatment. Patients who was fine at the beginning, but then suddenly the smear converts at 2 months or at 5 months. And patients who are smear negative, but they are not clinically improving. We must also remember our symptomatic contacts of patients, of families of patients with MDR-TB, and of course healthcare workers working in high-risk areas where there's not infection control. If they do develop TB symptoms, we want to have a very high suspicion of MDR-TB. So let's start at the very beginning and talk about how we diagnose drug-resistant TB. I won't be covering the symptoms and signs that might make you suspicious because they're exactly the same as for drug-sensitive TB. So when you have a suspicion that a patient might have tuberculosis, you're already wondering in the back of your mind, is this a drug-sensitive TB or may this be a drug-resistant TB? The important difference, though, is that drug-resistant TB is always a laboratory diagnosis. We can never have empiric drug-resistant TB treatment. Fortunately, in South Africa, we do have our GeneXpert as our first-line test for all patients where you suspect TB, and therefore we have an early indicator of whether patients may have drug-resistant TB. Very important with the rollout now of the new 9 to 12-month regimen, all patients that are GeneXpert positive and are showing Rifampicin resistance on that result will be started on MDR-TB treatment whilst you are waiting for confirmation. But very important, even though you've started treatment, we still have to have confirmation and also to establish what type of drug-resistant TB we might have. This algorithm you'll be seeing repeatedly through this presentation and has been designed by John Hopkins. And as you can see there, we're starting at the top there, right at the beginning, with a patient who's GeneXpert positive, RIF resistant, and that patient immediately is entered into the MDR-TB program. The GeneXpert results should have a fairly quick turnaround time, usually less than 48 hours, and will be able to help you identify both to make the diagnosis of tuberculosis, but also to be able to identify whether the patient has rifampicin resistance. If the GeneXpert is positive and the patient is rifampicin sensitive, then we call that drug-sensitive TB. And remember that we send a smear microscopy in all of those patients to be able to help monitor the response to treatment. We're going to be focusing on patients who are GeneXpert positive and rifampicin resistant. Very important, you have to now confirm what kind of rifampicin resistant patient this is. And we'll look at those definitions in a minute. What has been introduced as part of the new guideline is a test that we are calling the DRTB reflex test, which in some parts of the country may already be a true reflex test, might be done automatically. But at the moment in the Eastern Cape, this has to be requested. So if you see a patient who's GeneXpert positive, rifampicin resistant, the first thing you have to do is collect another sputum and send that sputum to the NHLS with a very clear label on it, DRTB reflex test. And that reflex test includes several things. It includes first-line LPA and second-line LPA. It will include the smear and culture that needs to be sent, and if indicated, it will include also the PDST for pre-XDR and XDR drugs, so for other possible second-line drugs. So let's look at this DRTB reflex test and some of its components. The first part of the test is to do the first line probe assay. And this is a great test. It's very similar to the GeneXpert, but it can tell us not only about whether the patient is rifampicin resistant, but it can also tell us about INH resistance. It does this by looking at two specific mutations, and it also gives us, therefore, not only whether there's resistance to INH, but whether it's a low level or a high level INH resistance. So the two mutations it looks at is the INHA and the CATG. The INHA mutation confers a low level INH resistance, and in those patients we would use high dose INH. Note that that particular mutation also confers resistance to ethionamide, and so you would choose high-dose INH instead of ethionamide. Conversely, the CATG mutation confers high-level INH resistance, but not resistance to ethionamide. So in those cases, we would not use high-dose INH and would use ethionamide instead. But if you have both mutations, you have a problem. It confers resistance to both ethionamide and high-dose INH, and neither of those two will be used, and this might be a patient who will be qualifying for bedaquiline. The second part of the reflex test is a second line probe assay, which is checking specifically for resistance to quinolones and injectables, and you will see how this helps us to differentiate between our pre-XDR and our XDR patients. And it's going to help us to modify that original regimen. So we've started our patient on our 9 to 12 MDR-TB regimen, but this will help to confirm whether we might be looking towards a regimen for pre-XDR or XDR. They will also be sent a smear for the same reasons as drug-sensitive TB. It helps us to monitor the treatment, but it also gives us a little bit of an index on infectivity. And then very important, a culture must still always be sent. Although the line probe assays give us very good information, quite often you need enough bacilli to be able to do the test successfully, and you might have to wait for a culture before you can get any confirmation. Just a reminder, the culture can take anything from 10 to 22 days, and then to do the DST on that, your drug sensitivity test can take an additional 7 to 12 days. So it might be a good 6 weeks before you have your results back. Also, the culture and DST does not have the same accuracy for all the drugs that it tests, and some drugs are not evaluated at all, such as PZA. Culture and DST becomes very important in patients who's previously been exposed to second-line drugs, especially your patients where you're thinking of pre-XDR or XDR treatment, as neither of the line probe assays are going to give you information on that. And so, in summary, DRTB is a laboratory diagnosis, and remember that all patients who are GeneXpert positive and rifampicin resistant must have a sputum sent to the lab for the DRTB reflex test. Thank you. Please see some of our other modules on drug-resistant TB, including modules on the baseline investigations, regimens, and HIV.